my name is Marissa and this is my video for chest tube assessment. So the first things I would do is I would wash my hands and I would gather my supplies for the assessment. So I would need my stethoscope, some clean gloves, and then also I have in the room is extra dressing supplies in case I would need to change the dressing. Also in the room that I should have at all times for a chest tube is a bottle of sterile saline water and again dressing supplies and a hemostat. So before entering the room, I'm going to go ahead and I'm going to wash my hands. I'm going to knock, 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 and I'm going to provide her privacy and say, "Hello, Jennifer, my name is Marissa. I'm going to be assessing your chest wound here. Can you please tell me your name and date of birth?" And she tells me her name is Jennifer Doe, 11/5/1975, and I would check her wristband, and Jennifer Doe, 11/5/1975. Yep, matches up. All right, Jennifer, I'm going to go ahead and I'm going to assess your vitals right away. So when I would assess her vitals, the vitals I would be assessing is her blood pressure, her pulse. I would put the pulse oximeter right on her finger to be checking her O2 saturations too. And then when I'm checking her respirations, I would check for the rate, the depth, if she had any pursed lip breathing or cyanosis. And then when I auscultate, I'm going to listen for any adventitious lung sounds. I'd also note that right now that for children or infant or birth to 2 years of age, abdominal breathing is normal. So I'm going to go ahead and auscultate her lung sounds right away. Alright, I did not hear any ambitious lung sounds. She does not have any pursed lip breathing or cyanosis. Her rate was 18, which is in normal range, and she had moderate depth, which is also in normal range. I would also auscultate the posterior side of my patient, but in this case I am unable to do so. And then I would go ahead and I would don clean gloves then. I'm going to wash my hands one more time here before putting gloves on. Alright, Jennifer, I'm going to go ahead and I'm going to lift up your gown here a little bit just so I can take a peek at that wound, okay? And she says, all right. So keeping her covered as much as I can, I'm just going to lift this up so I can assess it. And when I'm first initially looking at it, I'm going to be looking for any air leaks. I'm going to be looking for any signs of infection. And I'm also going to be looking for excess drainage. If there was excess drainage, this is again why I have my supplies to change her dressing change at this time. I'm also going to be palpating around the wound for any crepitus or any signs of subcutaneous emphysema. So everything looks good. I don't see any signs of any of that. So I'm going to go ahead and pull this down for her. And then I'm going to move down to the connection site here, and I'm going to make sure it's secure, whether it's a band or a tape or whatever they have on there. I'm going to ensure that that's secure. I'm then going to go to the tubing, and I'm going to make sure that there's no air leaks in the tubing. One way to check this is by checking the water chamber, and if there is any bubbling, that could indicate that there is a leak. Also, while I'm down here, I'm going to note if there's any drainage, and I'm going to note the amount that there is, the color of it, and any other characteristics. Also, while being down here, I'm going to note that the reason the chest tube is down here is because it needs to stay below the level of insertion of the chest tube. So then before leaving the room, I'm going to make sure, or I'm going to assess any discomfort that my patient is having with or without movement. I would encourage and teach the cough and deep breathing and the need to reposition every 2 hours. And then, so before leaving the room, I would remove my gloves. I would wash my hands. and put my patient in safety, put the bed down, put the rail up, make sure the call lighted is in place. I would then leave the room to go document, and documentation would include the assessment findings that I just received from doing my assessment, any interventions that I did or any teaching. Also, I would report any changes in the patient or any deviations from the norm. And then a modification that could be is if this was a child, I would probably have a parent in the room or another staff member if available, just because we don't want that child to be pulling on that chest tube to pull it out. And I believe that is it.